Hello everyone, you are watching sqadia.com, and now we are dealing with disease which is very common, especially in case of females, that is osteoporosis. It's one of the metabolic bone disorders. In this section, we'll be going through the etiology and its risk factors, postmenopausal osteoporosis, and what are the secondary causes of osteoporosis. Now, osteoporosis is abnormally low bone mass and defects in bone structures, which actually renders bone unusually fragile and greater than normal risk of a fracture. Usually, if a patient presents with a history of trivial trauma resulting in a fracture, for example, there was just a radius fracture due to fall and outstretched hand, or there was a neck of femur fracture due to just a simple slip of from a wet surface, or if there was some degree of compression fractures of the vertebra. These are classically usually osteoporotic fractures because the bone is so fragile and weak that it actually results in a fracture from a very low energy trauma. Now, if you see the etiology in a normal bone, although there is bone resorption and a bone mineralization is actually going on along side by side, that this osteoblastic activity and osteoclastic activity is going on, but it's very much balanced in such a way that the architecture of the bone is not affected. But in case of osteoporosis, there's primarily or predominantly there's bone resorption, that the osteoclast becomes high in activity as compared to the osteoblast. So the bone turnover or laying down of the bone is less, and bone removal or resorption is increased, and there is actually loss of bone mass. There is a decreased bone formation, but predominantly increased bone resorption. There may be both as well, but overall effect is such that the bone resorption is more as compared to bone formation. If you see in this diagram, this is a normal bone matrix, but if you can compared to osteoporosis, there is increased spaces and increased widening of the lacunae, as you can see that the bone has become more weak. Coming to the bone mass and bone strength, there is a variable degree of mineralization in case of osteoporosis. At sometimes there is that is there on some areas there is normal mineralization, and other there is abnormal. As a result, there is not enough calcium present in the bone, which is actually provides strength to the bone. There is a loss of bone strength. There is absolute diminution in bone mass. There is increased postmenormal bone resorption, perforations and gaps. There is slow remodeling rate in old age. So what are the risk factors for osteoporosis? One of the most common risk factors is actually the age. As we grow older, our bone remodels capability actually decreases. So our bone have become more fragile and weak as compared to bone of a young adult. Another common cause is female, especially if they had a previous fragility factor, that is a fracture due to trivial trauma. There is very high likelihood that she may be suffering from osteoporosis. Use of oral systemic glucocorticoids, I just told you that the glucocorticoids actually result in bone weakness and loss of bone mass. There may be a family history of hip fracture, because usually if there is always a family history of hip fracture, means there was something for a metabolic bone abnormality which was already present, which may be the cause of having a hip fracture now. Then low BMI, because they just do not have enough nutritional intake so that a normal bone can remodel in a normal way. As a result, even in the young females who have eating disorders such as bulimia nervosa and bulimias, they may have a BMI way too low than a normal 18.5, resulting in a fragility factor, osteoporotic fractures. Then it is smoking. Smoking is not only injurious to as it is injurious to many other organs, it is also catastrophic for bone as well, and usually results in increased osteoclastic activity. Alcohol intake, usually it's greater than 14 units per week for males, and for greater than 21 for females, but that is very difficult to determine how much a patient drinks, because usually those who are habit of binge drinking, they really don't know how much they have drunk. But on the long run, alcohol is actually one of the cause of osteoporosis, especially in case of females. This is an X-ray. It's actually showing a lateral view of the vertebra. If you see over here, this is T7, this is T8, 9, and 10. If you see this T11, it's also actually slanted. There is some degree of compression fracture over here as well. And if you see T8, actually there's collapse anteriorly as well. This classically, there is anteriorly compression fracture, which is due to weakness of the bone in case of osteoporosis. There is a common cause, one most common cause of osteoporosis, especially in the postmenopausal women. It's an exaggerated form of physiological bone depletion that normally accompanies aging and loss of gonadal activity. In females, especially, following post-menopause, there is actually a decrease in estrogen levels, which results in decreased bone mass. Around menopause, for the next 10 years, bone loss accelerates to about 3% per year. There's an increased bone resorption, withdrawal of estrogen having removed one of the normal restraints on the osteoclastic activity. As estrogen is an anabolic hormone, it results in increased osteoblastic activity. Once that is lost, there is actually increased osteoclastic activity, leading to increased bone resorption in females. Clinical features of these postmenopausal osteoporosis includes asymptomatic until sometimes they can be simply asymptomatic, or usually there are increased risk of fracture. There may be associated Cooley's fracture or the distal radius fracture due to just fall on the outstretched hand. The bone turnover rate is normal or slightly increased, because although bone turnover rate is increased, but predominantly the osteoclastic activity is high as compared to osteoblastic activity. So what is the treatment to this osteoporosis? Now, depending upon the age of the patient, whether it's male or female, and what is the cause, that's how we plan our treatment. Treatment includes, like, we have to give them drugs like bisphosphonates is the most common form of the treatment given to them. Then denosumab, that includes parathyroid hormones. For example, if the patient is hypoparathyroid, patient is actually not secreting enough parathyroid, so there is definitely not increased absorption of calcium. That is why their bones are weak. So they have, those hypoparathyroid patients have to be given parathyroid hormone analogs. Selective estrogen receptors in case of hormonal therapy for those female patients who are postmenopausal. Then strontium granulate also helps to protect bones. Then that is actually prevention of fracture and kind of a medical therapy, so that their bones become strong enough and they're not prone to fracture. But if the fracture has occurred, then we have to manage fracture accordingly, depending upon where it is, and that is depending upon, usually if it is distal radius, it could be conservative or it could be operative as well. Then associated physiotherapy needs to be done, because not only the bones are weak, the muscles and everything actually is weak as well, and the bone healing is also affected in some way. Usually, if it's a compression fracture, this could be treated either with a kyphoplasty or spinal orthosis. Kyphoplasty is actually called as vertebral augmentation, because in this the fracture anatomy is vertebral anatomy is restored by filling in the spaces left over by the fracture by bone cement, and eventually fixing this fractures with the vertebra above and below. So other option is simply, if the its vertebral kyphoplasty is not possible, is the vertebroplasty, that you replace the vertebra with a new vertebra eventually, so that the compression fracture is completely ruled out. If it's osteoporosis in men, this is usually the common site of fractures include wrist fractures, again due to fall on outstretched hand, vertebral fractures leading to compression fractures, hip fractures leading to AVN. The causes could be multiple. Mostly it is a secondary cause, such as hypogonadism, metastatic bone disease, multiple myeloma, liver disease, renal hypercalciuria, alcohol abuse, and malabsorption disorders. Now, the secondary causes most commonly include osteoporosis hypercortisonism, gonadal hormonal deficiency, hyperthyroidism, chronic alcoholism, and immobilization. These are all secondary causes, that although the problem is not with the bone, but due to them, the bone mass is actually decreased. Some of the other endocrine causes of this osteoporosis include, as I just told you, it's hypogonadism, hyperthyroidism, hyperparathyroidism, hyperprolactinemia, and Cushing disease, in which there is actually glucocorticoid excess. Or diabetes. Why diabetes? Because diabetes affects the kidneys as well as many other organs, is angiopathy, retinopathy, and vasculopathy. So overall effect on the bone as well, that there is actually decreased calcium absorption, so that the mineralization is affected. There's decreased blood supply going to the bone, therefore there's infarction. So overall the bone density and mass decreases in diabetes. Then respiratory causes include cystic fibrosis, smoking related lung diseases. Metabolic causes include homocystinuria. Then there is chronic renal disease, which is basically called as renal osteodystrophy, or this is due to the gastrointestinal malabsorption syndrome, such as celiac disease, inflammatory bowel disease, chronic liver disease, or chronic pancreatitis, and other malabsorption syndromes. Now there are plethora of causes. If a patient comes to you with these, there could be any of them, but we have to take out the detailed history and examination and rule out on by different immunological and biological tests that what is the most likely cause of osteoporosis in this patient. And rheumatoid arthritis and other, these usually patients actually on long-term steroids. So steroids in itself is injuries to the bone, resulting in osteoporosis in these patients. Other includes hematological, such as multiple myeloma, hemoglobinopathies, and systemic mastocytosis. Immobility is one of the major causes, especially following casting techniques or conservative treatment of fracture, especially if the patient is unable to move his or her joint, resulting in not only the muscle wasting as well as there's reduced bone mass in these patients as well. Or if this immobility be due to associated with neurological injury, for example, there was a spinal cord injury, or there was head injury, or some kind of a neurological disease which has resulted in paralysis. How glucocorticoids induce osteoporosis is actually been shown over here, that there's endogenous or physiological glucocorticoid. Endogenous is if there's any tumor which is producing extra glucocorticoids in the adrenal glands, or the patient is actually taking steroids for his or her treatment of rheumatoid arthritis. They all affect osteoblasts in a way that they actually, osteoblasts release beta catenin, which actually affect the mesenchymal cells to become chondrocytes as well as adipocytes. But as if this is affected, this overall activity of osteoblasts is decreased, resulting in increased osteoclastic activity, which would actually result in bone resorption, and overall effect is such that the bone mass density would decrease. Although there will be definitely somewhat reciprocal increase in osteoblastic activity as this increase in bone resorption, but overall effect is such that bone resorption is far more than the bone formation. In endogenous Cushing disease, or after prolonged treatment with steroids, usually it's present in severe osteopenia. Drugs are administered in itself associated with bone loss, for example, rheumatoid arthritis. Treatment is oral corticosteroid doses should be minimized, or at least if they can be tapered off, it's best if they can be tapered off. We have discussed one of the very common causes, such as osteoporosis, especially in postmenopausal females. And nowadays there's a lot of research and a lot of investments been on osteoporosis, because actually it's one of the most common cause of fragility fractures, especially as the world is population is growing old. With the increasing age and these metabolic bone disorders, especially related to osteoporosis, have actually resurfaced, and there are a lot of surgeries which have to be performed due to fragility factors. So definitely, if we can prevent these fragility factors, this will not only save the cost of treatment, as well as it will also help a patient to have a better life and a better bone mass and everything, resulting in overall decrease of fragility factor. Thank you very much. Keep watching sqadia.com.